So, welcome to the Hope Palliative Care Nursing Education Forum. This is a joint project between the Huron, Perth, and Oxford and Elgin Palliative Pain and Symptom Management Consultation Program. So, myself and Sarah, because we wanted to really give people an opportunity to look at literature and feel more comfortable with looking at literature, and then actually taking it and translating that knowledge into action. So, applying it to case studies and seeing how when we read something in a journal article, how does that actually land for us in our practice? So we'll start out today, we're gonna do some introductions. We're gonna go through our journal article. Why did we pick this particular article, which is Changing Practices in the Use of Continuous Sedation at End of Life, a systematic review of the literature. Then we are going to do a case study, again, to try and help us translate that knowledge into action. And then we'll leave some time for discussion at the end. So to start out, my name is Kate Garrant. I am a nurse educator and consultant with the Southwest Palliative Pain and Symptom Management Consultation Program, and I take care of Oxford and Elgin counties. And I'm here with my wonderful colleague, Sarah, who I will let introduce herself.
So hello to everyone, and my name is Sarah Givens, and I am the colleague of Kate's up here in Huron and Perth counties. And it's a very exciting opportunity and one that we are really looking forward to about approaching that, looking at evidence, not something that we have a university or anything really close by, looking at the evidence, looking at that expertise, patient preference, and bringing it all together for that evidence-informed practice. So really looking forward to it. I am going to mute, but be monitoring the chat box if anybody has any questions or anything as Kate takes over the first part of the presentation, and I'll be back in a bit.
We've got a great group of people from different places, a lot of hospice today. So without further ado, we will go ahead and get started. So the first thing we wanted to talk about, why this paper, why this topic? This topic was identified as a key priority for our forum. So we surveyed current and former CAPC students before we launched the Hope Nursing Education Forum. And the resounding topic people wanted to learn more about was palliative sedation. So we thought we should probably do that. Now, in keeping with supporting Canadian nursing research, which is always our first go-to, we started by trying to look for Canadian nursing-led research, and even reached out to a research librarian to assist us because we couldn't find much reliable literature on the topic. It was mostly opinion pieces and very little that was even nursing-based. We also did a search of the Cochrane database, which pointed to a lack of strong evidence on our topic. So as you can see, we ended up with a systematic review from the Netherlands that included Canadian research as part of its work. Of the 61 studies that were analyzed, only 2 were Canadian-led primary research. And while this isn't exactly what we were aiming for in the beginnings of our search, we also felt that looking at a systematic review would give us a chance to talk about this type of literature, because again, that's part of the aim of this education forum, is to also look at how do I know that I'm looking at good evidence? And we also didn't want to look at just one case of primary research in a topic that can be really ethically challenging. We thought that looking at a broader context might help us better understand our own use of continuous palliative sedation. So the aim of this specific paper was to gain insight in developments in the use of CSD in various countries and subpopulations. So in order to look at that, we are going to talk about what is continuous palliative sedation to make sure that we're all on the same page right off the bat. So it's important to note that continuous palliative sedation therapy is a specialized medical intervention that leads to the intentional induction and continuous maintenance of a reduced level of consciousness with the aim of relieving refractory symptoms that have not responded to any other treatments during the last hours or days of life for patients, where the primary goal of care is comfort. So it's not necessarily deep sedation. The aim is to always use the lowest dose of medication possible. Sometimes that's deep, sometimes that's lighter. Now, in the article, they use the term continuous sedation until death, or CSD, which aligns with our Canadian terminology of continuous palliative sedation. But the authors did note that the variety of terms in the literature covers everything from terminal sedation, palliative sedation, deep sedation, end-of-life sedation, which is one of the things that can make it kind of difficult to study when we're not all using the same language. Now, I wanted us to note that it's not providing small doses of medication to alleviate symptoms that, as a side effect, results in the patient being sedated. It's also not the temporary use of sedation when the symptom causes are reversible. So, for example, if somebody's in, let's say, an acute delirium, secondary to neurotoxicity, we give them some Nozadan to temporarily sedate them while we try to adjust their opioids. We might give them some hydration, try and reverse that delirium, and then lighten the sedation to see if it worked. That's not what we're referring to here with continuous palliative sedation. Now, it is relatively uncommon. Our rates of CPST vary in the literature because of factors such as definitions and settings of care. We know in Canadian community settings, which includes both hospice and our community nursing population, rates of less than 5% are often reported. We may see higher rates in places like the ICU or palliative care units where they have very complex cases. And in the article, they discuss quite a range of frequency. They kind of settle on a median of 3 to 18%, but they talk about everything from 1 to 81% in different locations and subpopulations. Now, I also need to point out CPST, which just for language, I will use CPST when I'm talking about us in the Canadian context, and when I'm discussing the article, I will switch back and forth to CSD. CPST is not MAID. It is not a form of or a substitute for MAID. And sometimes this can be confusing for people. So it's really important that we're very clear in our language and our intent. So MAID is the legal medical administration of lethal medications available to persons who meet specific eligibility criteria. The intent of MAID is to cause death to relieve suffering. The intent of continuous palliative sedation therapy is to relieve refractory symptoms and not to hasten death. And we know from research that has been done on people who receive CPST, they actually have been shown to survive longer and with fewer symptoms than those who did not receive CPST. So, what would qualify you as a candidate for palliative sedation therapy? We talk a lot about refractory symptoms, but what does it mean? So, it's not just a challenging symptom. A symptom is considered to be refractory if we cannot adequately control it without the intentional use of sedation. So it is important to note that the adequate control piece also takes into account that the treatment for the symptom would be effective in an acceptable time frame for the patient. So let's think about someone who's in intractable pain. We may be able to find alternative therapies, but it might not be timely and it might not be an acceptable risk for the patient and family. Which was why when we look at pain, it's sometimes a controversial indication because some practitioners would argue there's always something else that we can try for pain. However, when we consider an acceptable time frame and suffering of the patient, if CPST is consistent with their goals of care, it may be indicated. Now, more controversial than pain are indications like psychological, spiritual, social, and existential distress. Now, ethical use of CPST in any of these indications should look at a pretty wholesome consultation with team members, including palliative care specialists, spiritual care providers, bioethicists, and mental health professionals. And it is something that as we go through the article, they do talk about seeing a significant increase in non-physical, as they call them, reasons for using CPST. So an important note is that patients' potential future suffering. So the idea that I may eventually end up in too much pain or an agitated delirium, or the family's perceptions of suffering when the symptom itself is not refractory, these are also not indications for CPST. Now our criteria. So let's say they meet refractory symptoms, it is consistent with goals of care. We must have informed consent for no CPR or to allow natural death, which is our DNRC form in our counties. Their life expectancy must be limited. This is really important that we're looking at somebody with a life expectancy of hours to approximately 2 weeks. So we're not performing palliative sedation on people that we expect are going to be living for long weeks and months. It's really key that they are in that end of life phase. Now they have to have one or more refractory symptoms. We must have informed consent for CPST from either the patient or if the patient is not capable of giving consent from their substitute decision maker. And then this last one is really important. There needs to be consultation with a palliative care clinician or team. And that's important because when we're considering a symptom to be refractory, we need to make sure that we have really had a good palliative care set of eyes on the medications that are being used to manage, the non-pharm strategies that we're using to manage the symptom, and really making sure that we're giving them a good holistic assessment and making sure that we've tried everything before we're looking at CPST as an option. So getting into our article though, we are going to look at levels of evidence. So for those of you who joined us last month, we talked about how do you know that a journal is reputable, that we can count on the authors as people who we can count on what they're saying as being true. So our last article, we looked at expert opinion down here in the bottom of this triangle. We had a piece written by Harvey Chocnoff et al. About death, dying, and dignity in the time of COVID-19 pandemic. And for those of you who are familiar with Harvey Chocnoff's work in Dignity and Care, and as Sarah demonstrated last time, he is a very, very well-respected person. So an opinion piece by him, this is good stuff. Now, as we go up our pyramid, we get to systematic review, which is where we're sitting with this particular piece. We're not going to go through each one of these today, but as we walk through Journal Club over the next few months, and I hope you will come to all of our Journal Clubs, we are going to look at different types of things. We might look at some randomized control trials, we might look at case series and reports, but right now we're going to talk about a systematic review. Now, when I was looking for a great graphic to explain levels of evidence, I found a lovely quotation from the Center for Evidence-Based Medicine at the University of Oxford that said, "No evidence ranking system or decision tool can be used without a healthy dose of judgment and thought." So I thought that that really applied to our nursing practice, because when I think about all of the things that we do and all the tools and measurements and assessments that we do, none of them should be used without clinical judgment and thought. So let's talk about what a systematic review is. So for some of you, this might be great review. For some of you, this might be brand new information. So they start by systematically searching the literature to find primary studies that are related to a topic, then appraising that literature with a critical eye for study design and detail. And then they synthesize it to a better understanding of the topic. If we were to then go and perform a statistical analysis on that evidence, we would consider it a meta-analysis. So that's the very top of our little triangle there. Systematic reviews can be really helpful because when the reviewers adhere to a set of standards for completing systematic reviews, and there are actually set out standards for doing a good job at this, the conclusions are then considered to be defensible. So what that means is that we in practice, we can take those conclusions and we can look at how to actually apply that knowledge in our own practice. So we can do that knowledge to action translation. A proper systematic review must also be reproducible. So if I do one and then Sarah does one and then one of you does one, we should all be able to replicate the results. So let's be realistic. How many of us in our current roles have time to read through and synthesize all of the available literature on a topic on a regular basis? I'm seeing approximately 0 hands. And yes, because some of you have your videos turned off, but I'm guessing behind them there, none of you are doing these on a regular basis. So I looked at what they took to get this systematic review. They looked at 61 different studies to better understand how CSD is being used in different countries, and they hope to find information about what subpopulations have the most frequent use of CSD. But when you look at the results, they went from 8,128 articles. It just makes my head hurt thinking about that many articles and that stack of paper. They then went down to 4,078 after they accounted for duplicates. And then they did full text analysis on 160 articles. So imagine reading cover to cover, in depth, 160 journal articles. And then that came down to the 61 that were included as appropriate for this review. So it's quite a big undertaking doing a systematic review, but it also helps us in being able to go and look at, there are different databases that house systematic reviews, and you can go, okay, so this is a lot of information that's been synthesized down into something that I can probably draw some conclusions from and look at how I would use that in practice. So in doing this search, they had to look at different terms. They looked through major medical literature databases like PubMed and CINAHL and the Cochrane Reviews, and they looked at terms like continuous sedation, terminal sedation, palliative sedation, deep sedation, end-of-life sedation, sedation practice, and sedation until death, because again, we aren't all speaking a common language, which is one of the things in palliative care. If you've taken any courses with Sarah and I, we usually talk about how we all need to speak a common language. Now, speaking of common language, they did limit the articles to English and Dutch articles published between January 2000 and April 2020, which is important because it tells us that there may be other literature out there that has not been translated into English that may reflect different cultural practices, may change the data that we're looking at, but we don't have access to all of those. So when we look at it, we need to recognize that that is a strength and that is a limitation and a bias of this particular review. Also, when we're looking at evidence, an article, unless it's an article that was seminal to understanding a body of subsequent research, we really wouldn't consider anything older than 20 years. And I would even say that 20 years is pretty generous in how far back we would go in looking at literature. Sometimes we even limit to the last 5 to 10 years, depending on the topic. But again, for something like CPST or CSD, there isn't a great body of evidence to draw on, so they probably did go back a little bit further. Now let's look at our results. So the frequency of CSD use varied really widely depending on the setting and the subpopulation studies. So we saw 1% in Japan in patients with cancer in a particular palliative care unit over a number of years. And then in 1 year in a hospice in the UK, they had 80% of the people who were in that particular unit. So this really points to needing some significantly better research in understanding the why behind the variations. Why are we seeing 1% over here and 80% over there? That research just hasn't been done or isn't accessible, or the level of evidence isn't high enough to have been included in this review. Now, they also found a clear trend for the increased use of CSD for non-physical symptoms. So those are the things I was talking about, including fear and anxiety and psychoexistential distress. This is new. This is something that we're seeing an increase in, that historically we really stuck to those physical symptoms of, in terms of refractory symptoms. So they also noticed that there was increased patient and family requests for CSD, and we're going to talk about that in a minute when we look at our conclusions. In some countries, CSD is used to hasten death, but it wasn't a very significant amount. And again, that is certainly not the intent of CPST here in Canada. In all studies, more than 85% of patients died within a week after starting sedation. So that lets us know that in most of those cases, it was likely appropriate in that end of life timeframe. So to conclude, there was too much variation in subpopulations to observe clear patterns in the use of CSD, which is one of the things that they wanted to know. Again, the why. They wanted to know why we were seeing different things in subpopulations. They just didn't have the data set to do so. As well as understanding that increase in CSD over time, and if it is just related to that extension from physical to non-physical symptoms, or if there were other indications. They also posited that improved palliative care has resulted in a greater awareness of refractory symptoms by healthcare providers, that we are becoming more aware of CSD as an option to relieve suffering, and thus it's becoming more common. They also wondered if patients and families might just be more aware that it is an option. They noted campaigns to make people more aware of their options at end of life. And I was thinking about what we see in our counties with, we have a push to look at advanced care planning. How many of you have heard more about advanced care planning in the last couple months and years, as well as goals of care? And with MAID being legal, it's become even more important to make sure that people understand what their options are at end of life. So that may also be influencing why we're seeing more patients and families request it. Now, for me, the biggest takeaway from this article is in how we relate it to our own practice. Really, palliative sedation isn't going anywhere. We're seeing an increase in its use. And when I think about how our opportunities to treat people and try new treatment strategies continue to advance. Essentially, we can keep people alive longer with more complex medical issues. It's a valuable tool to have in our toolkit. So in a moment, Sarah is going to ask you about your own feelings about CPST, because it's important that we examine our own attitudes and values and beliefs and either dive into our comfort and move into action, or sit with your discomfort until you can integrate it into your nursing practice. I've done a number of palliative sedations over the years, and personally, it's not something that I ever want to have to do because it means intractable suffering is occurring for patients and for families. But I'm often reminded of a quotation from a lovely poem by Margaret Atwood. I would like to be the air that inhabits you for a moment only. I would like to be that unnoticed and that necessary. It makes me think about how sometimes our nursing practice in these situations is like that air. We're stepping in and out of people's stories. We're there to provide this vital tool in our toolkit, but it should not be about our feelings, our attitudes, and our beliefs, but about what relieves suffering to improve the quality of living and dying for those in our care. So thank you for sitting through my spiel on what the article was and how we look at a systematic review. I am now going to turn off the recording, and I'm going to turn things over to Sarah to lead you through the case study.
So as we move into our case study discussion, the first thing we talked about is regarding our conversation about palliative sedation. What are your thoughts as we go forward? And we discussed whether you can have different feelings, you may have different levels of comfort with the topic. And then we moved into our case study. In our case study that I'll let you read, we really dove into the history about Martin and looking at how he and his wife Martha are coping through his disease. So you can see he had diagnosis and treatment and then moved on to have metastatic disease. We included his ESAS scores as well as his PPS to be able to further the conversation. His current medication list is provided, showing that he's not on a lot of medications, but some that are routine and some that are there to help control symptoms. He does have his EDITH and DNR paperwork completed, and for the purpose of our discussion, he was not interested in MAID. Very important to note that at the end of our visit, that his wife reported he's starting to have some odd behaviors, such as commenting on people being in the room that aren't there. And his wife told us that this is very upsetting to the client and wondering about options if things get worse. So we talked about our conversation in what we know now. Do you think the nurse should initiate a conversation about what palliative sedation is? And the feeling in our group was that we should talk about what it is, provide some education to the patient and family and validate how they're feeling. In being able to do that and allowing them to absorb the medication, discuss it further, ask any questions. We wanted to make sure we had that conversation with the client and his wife as the substitute decision maker. We also wanted to have the conversation with who would be the most responsible physician or nurse practitioner, making sure we had good lines of communication and that we were able to have that conversation and allow them time to be able to plan and decide if they needed any further supports. We talked about the supports available. So within our organizations in the Huron and Perth area, I am there to help provide linkages and supports to those that need it. And Kate within the Oxford and Elgin group. We also talked to our palliative care outreach teams, as well as those that are working within the palliative care spectrum, our residential hospices, and other organizations. So at this point, we did not feel it would be appropriate to initiate palliative sedation based on the fact that we did not feel the patient met the criteria. So when we look at that criteria that is listed on here, we noticed that it refers to the Calgary guidelines is what we are talking about. So the Calgary guidelines can be found in Pallium, so can the Rosso guidelines as well. There's other guidelines that are out there. So we encouraged everyone to look at their organizational guidelines. And as well, there are some ones that we would recommend. For instance, the McMaster Family Medicine Division of Palliative Care has a recent palliative sedation guideline that they have put out in March of 2020 that has some good things and good references available. We would encourage people to look at that guideline. There are guidelines available through some of our other tertiary centers, and there's a few out there. And of course, we do reference back to Pallium. So the criteria to be met for palliative sedation is looking at that client suffering from a refractory symptom, the DNR order, and that they have been assessed or discussed with a palliative care specialist, and consultation with the client and family and substitute decision maker. And of course, that everything has been documented, including that important step for the nurses. As our case study continued, the visiting nurse was able to report the new finding of delirium, and the joint visit was done, and further education and support was given around the idea of the possibility of palliative sedation if needed. The underlying cause was felt to be not a reversible cause. Unfortunately, the delirium continued to worsen, and the client's PPS dropped to 20%. The wife was struggling with the behaviors, the patient was in an agitated delirium, and they needed to reach out to the family doctor. It was determined that the client was having refractory symptoms. So we asked everybody to think about, do you know what your organization's palliative sedation guidelines are? And to, if they haven't accessed them, to think about that when you went back and look at what your organization has. Again, we reinforce the resources that are out there to the nurses and to the family doctors, to not be afraid to reach out to your colleagues and to those working within palliative care that may be able to offer some support. We also then looked at the criteria and agreed that at this point, the client would meet the criteria for initiation of palliative sedation. We also made reference to that it's not just about the medication, but making sure that we are doing a good job of communicating and sharing with everyone what is happening, and that we have a plan in place, and then wanting to move forward with our next steps. So we talked about one of the things that's very important when you're talking about palliative sedation is determining what is our goal and our level of sedation. So we looked at the Richmond Agitation Sedation Scale, or the RAS, and looked at those terminology. Are we looking for a -2 light sedation? Are we looking for -3 moderate sedation and -4 deep sedation? And looking into those and understanding what is our goal so that we are making sure that we're clearly communicating that and working to titrate the medication to meet that sedation level and to help alleviate the symptoms for the client. So we talked about what sedation we would need, and that would help determine the dose. So the most common medication used in a lot of the guidelines that we reviewed would be midazolam. The other medication that is often considered in first line would be methyltrimeprazine or Nozanan. Not every guideline is the same, and that is why we recommended looking at the Pallium guidelines, and again, referencing your organizations or other guidelines that are out there to look and see how you would proceed. So then we talked about the monitoring and next steps. And again, you should always go back to your organizational protocol or policy or guideline to ensure that you are doing and making sure you are monitoring as per their guidelines. If you don't have access to that within your organization, there are monitoring suggestions that are out there based on the level of sedation that you are attempting to achieve. But you need to have clear communication with your level of sedation goal, and meaning that you need to have clear communication between those working within the team, with those creating the orders, with the families, and everybody who's involved in that care. We talked about ongoing supports for the family. Unfortunately, what precedes this conversation about palliative sedation, as Kate mentioned, is that the client was suffering from a symptom that was not under good control and was refractory for them. So we need to make sure we have ongoing supports for that family and reaching out to supports to ensure they are adequately supported during this time. And then also thinking of the client's quality of life. So when we talked about this, we highlighted the fact that we need to keep treating the symptom that is the reason that we were going forward with the palliative sedation. So for instance, if the patient was suffering from dyspnea and from refractory dyspnea, we want to make sure to keep continuing to treat that. If it's pain, we would still want to continue to treat their pain as we are providing that palliative sedation. So the next steps, if midazolam is not effective and the Nozanan is not effective, and when in Pallium, they define that the midazolam may not be effective if you find you're giving more than 10 milligrams per hour, then they do make recommendations about moving on. And one of the recommendations is around the use of phenobarbital. Depending on the guideline you look at, it can be given in addition to either the Nozanan or midazolam, or it may be given in replacement of. In very rare cases, they would move on to the final option. So we did mention the considerations. And as a visiting nurse, as a nurse working in hospice, or a nurse working in long-term care, hospital, anyone, you may have had a chance to really gain a relationship with the client, or you may have just met them. But either way, watching somebody suffer from a symptom that requires palliative sedation, you need to remember about self-care. You need to take time to debrief with your organization, with those, or reach out to those in the palliative community that can help offer you that support. And again, there may need to be ongoing supports for families. So consider whether you need bereavement supports, whether there's linkages that you can make with your community hospice, or how you can provide that. And also thinking about the different transitions and challenges based on the settings. So what you may be able to accomplish in a palliative care setting in a community hospice, residential hospice, may be harder at home or in long-term care. You may have a client that chooses to start their end of life journey in one location and may be transitioning to another. So always to be thinking about those transitions and understand the challenges in the different areas that we can have. So just a few things that we want to highlight as we wrap up our conversation and thoughts that came out is there is benefits to having these conversations with the patients and families earlier in the disease course and allowing them time to absorb and ask questions, letting them know that if they have a concern, if they're worried about something, that we are proactively working with them to provide the best care. We also want to make sure and to highlight the fact that palliative sedation is not euthanasia. That is not what it is delivered as and not what it is. We don't deliver it with the intent of shortening life. We are delivering palliative sedation to control symptoms. Also highlighted the fact that we didn't talk about opioids being given because we don't use opioids for palliative sedation. It's not about starting them on a medication such as hydromorphone or morphine and continually putting up the dose until they are sedated. Obviously, we use those medications as needed to control symptoms, but we wouldn't use them for palliative sedation. And also to really encourage people to look at guidelines, whether it is the McMaster guideline, as I mentioned, your organization's guidelines, Pallium, or whatever it is, but look and be following those guidelines. Set a goal of sedation level. It is important for you to do that so we know what we're working towards. And remember, you need to communicate. That's such an important part of this process and with any when we're working with patients towards end of life. And just a quote to wrap up and remind everyone that if you can't pay it back, pay it forward. So what we learn in these discussions, what we learn from talking to clients, what we learn from working through palliative sedation, we can help use that knowledge gained and pay it forward. We can use the information that we gained from our presentation in the Journal Club about the research, the clinical expertise that was shared within our group, as well as the patient's wishes and preferences towards providing that evidence-informed practice. So a reminder, if you're watching us on YouTube, that our next session will be November the 24th, 2020, and it is from 7 to 9 p.m. The topic will be about dyspnea at end of life, and you're happy to contact us if you wish further information. All the references for the information provided in today's slide, including the guidelines that we referenced and Pallium, are listed here on our reference slide. Take care.